Okay. Hi, everyone. Welcome to today's lockdown conversation. Very warm welcome to everyone. And today we have Dr. Vikramjit Mukherjee from New York. For those of you who don't know, he was on the show 5 months back, sharing his learnings and making some amazing predictions and showing us the way very early on. This was, if I remember correctly, 31st of May. And this is a conversation series where I have brought a varied set of speakers every other weekend during the lockdown. My name is Ravindra Jhunjhunwala. Vikram, thanks. How are you?
Thanks, Tej. Hi, everyone. Thank you for making the time, and look forward to a engaging conversation for the next hour. And I hope you and your families are safe during these testing times.
So for those of you who were not there in the last conversation in May, very quick introduction. Dr. Mukherjee is a critical care specialist and is the director of the medical intensive care unit at Bellevue Hospital in New York City, which is the oldest hospital in the US and serves as the tertiary referral center for city's public health system. His academic interests lie in providing care for patients with special pathogens, mass critical care and ICU operations. Incidentally, he's also my brother-in-law. Vikram, we are very lucky and truly honored that you're going to spend the next 60 minutes with us once again and share your learnings from New York, answering some of our questions. So thanks a lot. Once again, great job that you as a doctor and all the other medical fraternity is doing to lead this fight, the fight against the coronavirus. For those of you attending, same conversation format, 60 minutes as before. We start with questions which we have collected from all of us, and subject to time, we sign off with an open house through the chat box, and maybe we'll even switch on, give some of you an opportunity to ask questions. I will mute all of you. I think I've already done that, except our speaker, so that the quality of audio is consistent. But feel free to use the chat box function for any additional questions that you have. We have a fair number of people who have joined and are going to be joining from a very different background, different geography. So very quickly, and if we can start the poll, there are two questions which we thought we will ask. One of which is the age group that you fall in, and the second is the more difficult one, whether you or someone close to you have been COVID positive. And it's up on your screen right now. This is being streamed live on Facebook, but unfortunately the poll will not pop up there. So for those of you on Facebook, and I know a number of you are there are two questions on the screen. First one, what age group do you fall in? Below 30, between 30 and 50, and above 50. And the second one, whether you or someone close to you have been COVID positive. I'll give 30 more seconds before I end the poll. This will give us a little idea of the attendees today. Okay, I'm going to end the poll now, and if we can get the results across, it should be on your screen now. So Vikram, a large number of people are in the 30 and 50 age bracket, but almost equal number above the age of 50. And I'm actually quite surprised to see that more than half of the people who are attending right now at this point, more than half actually have someone or they have tested positive. So That'll give us a little bit of context. I'm going to get rid of the polling, and let's start with the questions, Vikram. And thank you a lot. Many of you have shared, taken time out, discussed these questions. I am going to bucket them, and as I have discussed with the speaker, we've grouped them. And what are we going to discuss today? Broadly, 6 big buckets: the state of affairs, whether we've dropped our guard, herd immunity, the update on vaccine, generally on travel safety, and most importantly, on medical learnings about the virus. So, Vikram, last time when we spoke 5 months back, you mentioned the experience was about 3-4 months with this virus, and you mentioned about the ugly face of COVID in US. The virus shouldn't be trifled with, and the data and the evidence was limited. So if I may ask you generally with respect to the state of affairs today, and very fair that you are based out of the US, so we get a sense of what the state of affairs in US is, but generally and broadly, what do you think the recovery rates look like now? Maybe we can start with that, and then I have a few more.
Sure. Thanks, Rich. So again, thank you everyone for joining. I think I'll start off by saying that, this is a once in a century pandemic. The last time the world saw something of this level is back in 1918, 1919 with the Spanish influenza, which killed millions of people and affected millions and millions of made a lot of other people sick. Now, we have to learn a lot from the experience there, just because we should recognize that in the 1918-19 influenza, the second wave killed 5 or 6 times more people than the first wave. And not recognizing that will be a little bit of ignorance on our part, because as you know, history repeats itself, and we should recognize that even though the first wave in most parts of the world has come and gone, the second wave, the US is in the middle of the second wave right now. And as you can see, back in the spring, it was parts of the US that were affected, the Northeast, New York, Chicago, New York, Boston. But right now, the entire Midwest, parts of Minnesota, the entire middle of the country is essentially is burning. Many parts of the country in the US have no ICU beds left, and it's a shame because it's been politicized, where being a mask wearer makes you lean politically and so forth. And a lot of these deaths, in my mind, could have been prevented with following signs. Now, the situation in India is also concerning, no question. We can see, though, that the numbers in India are not as roaringly high as they are in the US, but a lot of that might have to do with the level of testing that is also going on. We should recognize that winter, especially in the US, is coming, and this virus will take a huge impact on lives as the winter comes in. So by no means has this gone away. In fact, the thinking is that it will remain in the community for many, many years to come, but the way we get affected by it once a vaccine comes out and is deployed will be in a much more moderate form than before a vaccine comes out.
And I can add to that, Vikram, speaking with friends in Europe and other jurisdictions, whether it is Sweden, Norway, UK, Germany, France, Italy, Spain, just about everybody is going through a second wave. This week, they went into lockdown, and the restrictions are as severe, and maybe in some cases more severe than the first time. So may I ask, what are the reasons for a second wave, and is there something like a third wave?
Yeah, that's a great question, Jeet. So essentially, we know there are a lot of things we know now since May. One is that this virus is very infectious. It transmits from one person to another person very easily, more than the flu, more than most other respiratory viruses. The other thing that makes this virus really difficult to control is that you have a fair number, up to 33% of patients who have the virus in their lungs and their respiratory tract with no symptoms whatsoever. So this makes infection control really difficult, because if someone has a fever and a cough, yes, you can isolate that person, quarantine that person. But in this case, 1 out of 3 patients will have no symptoms whatsoever, yet will transmit. Well, that makes it a really catch-22, where you really cannot identify a patient who has the virus easily. So the reason the second wave is being seen in many parts of Europe is because many parts of Europe and the US have ended their lockdown, and that had to be done because of the huge financial and economic toll that the lockdown was taking place. But as the lockdown ended and people came together, became more social with each other, went to schools and colleges, went to work back again, went to bars and restaurants and stadiums, um, the virus is still there in the community. There is no herd immunity. So it's really not a surprise that cases have gone up again. In my opinion, this is going to happen again and again till a vaccine is developed and deployed, that as there's another lockdown in many parts of Europe, as the virus numbers come down, the economy will start opening up again. As the virus goes up again, the economy will close again, and this will be back and forth till we have herd immunity, which is a far, far way to come.
And I have questions on both the points that you raised, the economy opening up, herd immunity, and a few other things. But before that, you mentioned about the cold weather. Is there a linkage between COVID? I mean, influenza, yes, I appreciate and I understand, but is there a linkage between COVID and the cold weather? Because I read some studies which seem to suggest the weather has absolutely no effect on the incidence of COVID. So your thought?
Yes, so a few things play into that. One is, especially in temperate climates, people who live on top of the certain latitude, it's cold, it's snowing outside, many people congregate indoors. And if you don't have ventilation good ventilation inside your apartments, inside your flats, inside your restaurants, the COVID particles can persist in the air for a much longer duration and therefore transmit much easily. That's one. The second reason why winter is always going to be precarious is because the virus itself lives longer on surfaces in winter than in summer. And thirdly, influenza historically affects more people in the winters. And if you have your ICU beds and your hospital beds completely inundated with influenza patients, that reduces the capacity to take care of patients with COVID on top of that. So yes, most places in winter will see a much poorer outcomes.
Okay, so let me flip this and ask you, do you feel that during the summer months, the incidence of COVID was lesser?
Yes.
Okay.
I mean, the drop that we saw in summer was because people were outdoors, not very close to each other. There was good ventilation outdoors, but all those things, all those protective factors will go away in that few months to come.
Fair enough. I just have one question before I move to the next bucket. And, we are still debating in India whether we've had the second wave, whether we'll ever get the second wave. And when I had the epidemiologist Ramanan speaking on the show last time, he mentioned that he predicted actually, that probably we won't have a second wave, and the first wave and the second wave will combine. And that's when you'll see a peak and it'll go down. So I take your point about testing and how many are being tested, but cases are going down from 100,000 to 70, 65, 60. So what is your view about India second wave, whether we'll have it, we've had it? I mean, I won't hold you because you're practicing in New York, but just broad thoughts.
Yeah, no, those are good questions. And I follow the India data very closely as well. One is the mortality numbers in India are reassuringly low compared to the US and parts of Europe. One of the reasons behind that is because India, as you know, has a much younger population compared to many European and American countries, and advanced age is a big risk factor for poor outcomes. And by poor outcomes, I mean ICU admission, being on the ventilator, death. And one of the reasons why I think India has a lower mortality is because we have a younger population compared to the US. The second thing I have a bit of concern is that the testing needs to be done in the rural areas, in the villages and the towns, which are not as well equipped as the big cities like Bombay, Calcutta, Delhi. And I have a little bit of a concern of how deep we can go by testing. I know we're testing close to 1 million people a day in India, which is amazing. But for a country of 1.3, 1.4 billion, there is a space to further deepen testing. And unless you are testing a fair number of your community, getting reliable numbers which are important for source control are very difficult, especially because contact tracing is going to be very key. So if you test me if I'm positive, you need to test my wife, my kids, my immediate surroundings, and then isolate them if they're positive. And that would be the one way to go to get a control of this.
Fair enough. Thank you very much. Can we get the next poll and the last one? And before I move to the next section where I want to understand whether we've dropped our guard, this question is a very simple one, and it'll pop up on your screen if you don't mind responding to it. But while it pops up, I'm generally going to ask you the question, and it's about this whole discussion around life and livelihood, people wanting to get back to the normal lives. It's been a long time, and perhaps maybe even dropping their guard. So I'll club a number of things which I had in my mind, and I'll ask you. One is people getting back to daily business, socializing with Diwali around the corner, and of course Durga Puja and everything in Calcutta and Navratri and all of that. A lot more socializing, a lot more, card parties, food home deliveries, and grocery, whether I wash it or I don't need to wash it anymore, fruits cleaning, etc., etc. General thought on are we dropping the guard? Can we drop the guard? What is it that you feel?
Thanks, Rich. That's a very really good question. So I want to mention two factors. One is the science behind it, but also the differences in human behavior that are inevitable in a lockdown of this extent. So one is the science behind it is scientifically there really is no reason that we should be dropping our guard. We know that herd immunity comes when there's 70 to 80% of the population that has antibodies or has had an infection or a vaccine. And even in a place like New York, which was the epicenter, at best it's 20% in most communities. So, I mean, this is why you see in Europe when the guard or the economy opened, there was really no herd immunity, which is why you're seeing surge in cases again, though they had a significant wave back in February and March. So scientifically speaking, it is a little bit premature to drop the guard. I personally am not socializing. I'm keeping it only to work and home. And I remember that you said that most of the people in this discussion are 30 and 50. So most of us, that age group, will do just fine even if they have the COVID. The danger comes is that when you bring it home, who do you bring it to? If you have a young kid at home, those children might not be doing too well if they get an infection from us. More so if you have your parents living at home. We know that age more than 65 is a big risk factor, and the worst case scenario is you socialize, you go out, you bring the infection back home, and unfortunately give it to a loved one in your family. My parents were here a few months, and we absolutely banned any socializing for us and obviously for our parents for the 3 months that they were here. So I would, it's easier said than done, but this is the time not to let your guard down. Even one family member is too much to fall sick, as you know. And I would love to hear. The reason I say that is because 60% of us on this call have had COVID or have had someone close to COVID. So you know the bad face of this. And without herd immunity, bringing this infection home is just not a prudent thing to do. So that's the scientific part of it. We have to factor in the human behavior part of it, though, and it's being at home for 6 months now has to be playing mind games and frustrating people. Most of us are professionals here and have lived on a life of office and meeting with friends and so forth. So this can have huge psychological impacts, and there is no easy fix to that. There are some things that can be done safely, like bringing groceries home, wearing a mask at any time when you have someone home, maintaining 6 feet of distance. We'll talk about that a little bit. But overall, the cleanest thing to do is to keep our guard up as much as we can.
Thank you. The poll is up now. So if you don't mind trying to respond to it. And for those of you watching on Facebook, there's a live streaming going there. The poll won't show up. The question is, have you eased your lockdown? Have you dropped your guard? You know, in any of the following: travel, socializing, going out, etc., etc. And it's a yes or no answer. And surprisingly, it's half and half, Vikram. So I'm going to, I don't know whether you could see the results. It's half and half.
Yes.
So I'm going to take this off. And your thoughts?
No, I get this. It's very difficult to lock down. And honestly, the more irritating part is that there is no end in sight. We don't have a vaccine yet. And even if there is a vaccine, deploying it across 300 million people in the US and 1.4 billion people in India is not going to be an overnight event. So I get this. If you are committed to easing your lockdown, I would suggest that you do it in as safe a way as possible. And we'll come to some infection control measures that you can practice. Travel is always risky. Remember, traveling in a plane, even though the planes nowadays have really advanced filtration technology, it still is a risk factor. You're still in a closed environment with hundreds of other people. So non-essential travel should be looked down upon. And if you have to socialize, I would say that do it in as safe a way as you can. The best practice being not to, especially if you have at-risk people at home.
Since you touched upon travel, we may as well finish that section. And if you want to add anything about travel safety, we can probably finish that and then move to the main section, which is medical learning. But I also have a personal question, if you allow me to ask, but after the travel part.
Okay. So let's stick to air travel, because that's where the most of the data is. So air travel is risky, no question. You are, like I was mentioning, in a closed environment with potentially up to hundreds of other people with closed ventilation for hours on end. So I would suggest non-essential travel be clamped down as much as you can. Of course, there is an essential travel. For God forbid, you have a family member who's sick in a different city and you have to visit, that I would call it essential travel. So if you have to travel, you should be taking some safety measures to it. One is starting not just in the plane, from the airport, where you have a large congregation of people entering into a closed space. Masking should be there, preferably N95 masks. So, Jeej, if I have the chance, I would like to just discuss what are the different types of masks and what they do.
We are going to ask you that question, but go ahead. We can do it now.
Okay. So there's different types of masks. The simplest one is the cloth mask. Please remember that is good for controlling. So if you have an infection, that cloth mask decreases the amount of infection you would transmit to a friend or a neighbor. It does not protect you. The surgical mask, similarly, the N95 mask, which is tight and honestly quite difficult to wear for hours on end, is the mask that protects you if a person around you is infectious and coughing and sneezing. So I would just like to clear out that the possible misconception that a cloth mask or a face or a surgical mask does nothing to protect you. It protects your neighbor, your friend, your partner, and so on. So back to the airport. As soon as you're entering the airport, you should be, if possible, wear an N95 and wear a face shield. While you're in the plane, you should try to distance yourself. So one of the things that some airlines here are doing are emptying out the middle seat. So there's at least 3 to 4 feet difference between a distance between two passengers. You remember the air vents on the top where you have the fans. You should try and direct the fans away from you so that you don't have fresh air blowing into your face, and consider using a face shield as well. And the risk not only is there in the airplane, but also in a busy immigration part, in a busy waiting room, in a busy lobby. Similarly, when you're exiting in the security line and so forth. So don't let your guard down when you're in the airport, but outside the airplane.
So what I'm taking away from this is N95 mask is really the gold standard, but you don't have to wear it all the time. Wear it when you are exposing yourself to a situation. And when everyone wears a mask, there is more efficiency in protecting ourselves. So one thing, you alluded to about 6 months boxed up, and there was an interesting question which I pick up from the chat, and it's about how are health workers, how are doctors emotionally dealing with this being in the front line for so many months, and in your case, what are you seeing inside the ICU in the hospital, because you're seeing it very closely.
Oh, it's difficult. Geez, thanks for bringing that up. So healthcare worker wellness is a big avenue that we're exploring. Around 10% of all infected patients will be healthcare workers, and it's mostly frontline doctors and nurses, more so the nurses, honestly. And we've had here in New York City very close friends, very close colleagues, not only falling sick but also dying of COVID back in the spring, and it takes a huge mental toll on anybody. Addressing, if you're in the medical profession, addressing your team's healthcare wellness is a huge component of preparation. Just because we don't have a team, then your capacity to take care of infected patients when they come back is severely limited. I think the biggest struggle to me was in the height of a pandemic, the equation of whether I should be coming home to very young kids or no. And I think the depth of the abyss here was when my 1-year-old had a fever. Thankfully, it wasn't COVID, but the drama around whether I brought something from the hospital, was asymptomatic, and gave it to my 1-year-old kid was, I think, the lowest point of my experience here. So it's definitely something to consider, especially if you're in the medical profession.
Sure. No, thank you for sharing that. In fact, maybe it leads me nicely into my next bucket, and this is really the most significant part, if I may, of this conversation: the medical learnings about the virus. The last 5 months, we spoke in May this year. So the last 5 months, what have you learned new about the virus? And the first one I really wanted to ask is, how are you managing asymptomatic cases?
So it's a challenge. The best way of doing that would be a very sophisticated and developed contact tracing program. So not me, but our city here is doing a really good job in being able to identify people who are infected and then going to their community, trying to ask who this person met in the last week and testing every single person. What New York City is also doing is, because New York City has one of the lowest rates, the New York State has one of the lowest rates of infection currently in the US. Any person traveling to New York State from anywhere else in the country is being asked to test twice, once on admission and once 4 days into admission. And that kind of contact tracing is what's helping in being able to keep the numbers down. That, of course, needs a lot of resources, both in testing and manpower. So not an easy thing to do, but that's one thing that is helping keeping our numbers down a lot. The other thing that we should recognize is that China, which was the origins of this, now has one of the lowest rates of infection in the whole world. And the way that they did it is very difficult to do in a democratic place like India, where they essentially locked people down physically in their houses and didn't quite matter whether they were alive or doing well or not, just to clamp down on the infection. They put people on forced lockdowns for months to come. And that is great in China, but impossible to do in India or US. So great testing would be the way to go. So if you, for example, if you have someone who's confirmed COVID in your family or in your friend situation, you might consider, especially if you have at-risk people at home, to get tested.
Okay, so I was going to ask you about contact tracing and whether it is at all possible and whether it needs to be taken seriously. You answered that question. The other one which I wanted to probably ask at this time, you mentioned about tests, how many days, you mentioned 4 days and something. I just wanted a sense, what is the US practice? Because in India, as far as I understand, and I may be totally wrong about this, for those who are recovering post-COVID, under the ICMR norms, there's no mandate for testing for a corona negative testing. So, question: what is US doing, and should this corona negative testing be mandatory before a person who is or was corona positive moves out from isolation?
Okay. That's a good question, Tej, and we are struggling with this as well. So if you mind, I'll just go over the natural progression of the disease, because some of these chat questions are alluding to that as well. So for example, suppose I come in contact with a close friend who is COVID positive. I'm unknowingly get the transmission of infection. For the first 5 or 6 days, I will have no symptoms. The average duration of symptom onset from exposure is 5 days. It can happen between day 1 and day 14, but the average is 5 days. After 5 days, I'll have an infection, and I would test positive if I was truly infected. My symptoms would last in moderation for the first 6 to 7 days. And if I was to get really sick, it would happen on week 2. So on day 12 to day 14 is when, if I was to get sick, I would get really sick and possibly get admitted or possibly go into the ICU. The recovery phase can depend a lot, depending on how healthy the person was to start with and how much of an inoculum dose the person has got. So if someone has sneezed in my face and I've received a lot of virus particles, I'm bound to be more sick. If I've just walked through a person who's been there, the amount of virus that I've been exposed to has a lot to do with how sick I'm going to get. The CDC guidelines here say that between day 10 and day 20, you can lift all precautions. However, in the ICU, where people are much sicker, we are doing a second test before we lift precautions, just because we think that people who are sicker can harbor the virus particles for a longer duration of time. So if you're at home and you're not very sick, after around 14 days, you do not really need a negative test to lift all precautions. However, if you're in the hospital or God forbid in the ICU, you should ask for a second test before you lift all precautions.
That's very helpful. It answered a few other questions that I had on my sheet. But moving on, regarding protocols for therapy, has a lot changed worldwide in the last 5 or 6 months since we last conversed on this medium. And generally, what has been your advice apart from isolation? What would be the protocol with respect to medication and precautions? So if you can just elaborate a little more on what you were mentioning in terms of protocol and prescription, etc.
Yes. So over the last 6 months, there's been a host of scientific discoveries in this field. One of the few successes, and I mentioned few because most of the trials have been negative, has been the development of an antiviral. It's called remdesivir, and it's now FDA approved. It's approved for patients who are admitted with a drop in their oxygen saturation levels. And unfortunately, the benefits are not that great. It does not change mortality. It does not change your chance of going into the ICU. All it does is it improves the duration of symptoms and cuts your hospital length of stay. So recognizing that, it's part of our protocols now that if anyone is admitted to the hospital or into the ICU, we would use this medication unless there's a contraindication. Contraindications are essentially if you have underlying kidney disease or liver failure. But again, this is not a golden solution. It will not help save. It has not been shown to save lives or cut the risk of being on a ventilator. It helps you in terms of getting home quicker, getting a fever curve better. The other big therapy that has shown to be of benefit is steroids. And this we knew from non-COVID data as well, but if a patient is admitted with pneumonia and COVID, giving them steroids helps. A large component of how COVID makes us ill is by uncontrolled host immune response, and the steroids help mitigate that and improve. This one actually has been shown to improve mortality. There have been a lot of other studies that have unfortunately been negative. Convalescent plasma has been studied and negative. Antibodies, one of the Eli Lilly trials that was done has been cut short because of pre-trial absence of efficacy. There's tocilizumab, which was an anti-IL-6 inhibitor, has had a negative study. And there are a bunch of other studies which have been even stopped before completion because of pre-trial absence of benefit. So unfortunately, 2 drugs out there, and one of them, remdesivir, has been shown to only cut hospital duration, no change in major outcomes.
Very interesting for those thoughts. And in fact, somebody did ask on the chat about the Eli Lilly efficacy. So thanks for answering that. Has the character of the COVID itself changed from the time it first emerged to now? Has it become milder? Or it's a chronic condition, or is it getting deadlier? Has it mutated? Will it mutate? Has it lost its virulence? Generally, I'm putting a lot of them in one bucket because a lot of questions around that. So, your thoughts?
Those are great questions, Rij, and thanks for sharing. We really don't know yet. We know that the New York City strain, the strain that hit New York City back in spring, came from Europe, and it had certain novelties to it compared to what was going on in Wuhan in early January, February. Things that make the New York City strain a little bit different is that the amount of renal failure we saw in New York City was much more, 10 times more than what we saw in Wuhan. And that caught us off guard, but we attribute some of those differences to the viral mutation. Just historically speaking, just like the flu and other coronaviruses, we expect this virus to mutate. To be honest, this is a very smart virus. It is not that lethal that it completely kills its host and reduces its transmissibility. But it is very infectious, and it already has shown some mutations at a genetic level. So we do expect some mutations to happen, just like any other respiratory virus as the time goes by. Some of these mutations will reduce the danger. Some of these mutations will definitely increase the danger of this virus.
It's still scary, the way I understand it. And I don't think people are taking it as seriously as you say.
No, Rij, I'm in tune with some of the US data, and as we know here, there's been more than 100,000 cases in the US for the last 3 days. And when I talk to my colleagues in places which are getting hit hard, the Midwest, Minnesota, Chicago, they're essentially out of ICU beds now. And 100,000 cases today will essentially mean you'll need 10,000 ICU beds 10 days from now. And many of these states will be completely crushed and are completely getting crushed right now, having to deal with rationing care, which is a disaster scenario. I mean, we have now, even in parts of Texas, 10 patients coming in with 1 ventilator, and people have to choose who to give that ventilator to. So badness.
So some questions from those who have recovered, and there are quite a few, so I'm going to try and frame it in my mind and ask you, are there any side effects that you're observing from COVID recovered patients? I've heard a number of cases where in the same family, different people, different symptoms with impact on lung and the heart. So what is the truth, and what do you do to minimize some of this? Are there any markers to keep a check?
Great. So there's a huge and wide variation on how recovery looks like. Some people, if you check their antibodies, which is a marker of previous infection, will screen positive for antibodies and wouldn't even know that they have a COVID infection in the past. So that's the best case scenario where, like we were saying, 1/3 of patients won't have any symptoms. Some of us might have had no symptoms, had the infection, and now have antibodies when you test them and have no residual symptoms at all. So that's one bucket. The other most extreme bucket is someone who's had the horrible COVID, has been in the ICU with COVID pneumonia, and has had extrapulmonary involvement. Many of those patients, at least in our setting, have had months and months. So we saw our surge in March. It's been 6-7 months since then. Still have significant residual symptoms and weakness from COVID. They come in 3 major categories. One is residual lung weakness. One is, so many of our COVID patients had heart inflammation, and some of them have persistent heart inflammation. And then thirdly, overall muscle weakness, deconditioning, and need for physical therapy and rehabilitation.
And how bad are going the long-term effects going to be, and what care should be taken post-recovery?
So the biggest care that we should be careful about is someone is admitted to the hospital. We don't bring him or her home too quickly, too prematurely, where the patient is still infectious, and then the entire household now has become a hotspot. But if you are safe and able to come home, we should focus on a big component of physical therapy, lung rehabilitation, lung being the primary organ that is affected, and then a fair amount of nutrition and things to bring back strength. We still have patients who were affected in March who have not come back to 100% baseline.
Wow. And the last two questions that you answered with respect to what side effects you're seeing in the long-term impact. What about children? We've talked probably about adults. Do you think the same applies to children as well?
No, the one good thing about this is children don't seem to be as badly affected by COVID as adults, and more so elderly patients are. Which is great, because the last thing we want is this to be a big reason for young kids to fall sick. There are a couple of challenges in children, though. The number of asymptomatic carriers in children are higher, which makes it really difficult for schools and even colleges to identify patients and control them. So at least in most parts of US, the approach to opening schools has been very guarded. And a lot, and probably true in India as well, a lot of education is going on remotely through video schooling and so forth, or homeschooling. And I think that is a very rational thing to do, simply because even if the child doesn't fall sick, he or she is going to a place where many other children are there. Children, as you know, it's very difficult to put a mask on, and there will be close proximity to potentially infected patients, and then bringing the infection back home and becoming a hotspot. So video schooling, Zoom schooling is a very smart option to do in this setting.
Understood. And coming down to repeat cases or second-time corona, I have friends and some dear ones, and I see them asking me the question. They're probably trying to challenge COVID. So two questions actually. One, after how many days of testing corona positive should we actually test for antibodies? And I think you mentioned, but I want you to restate it. And until when do the antibodies last?
Okay.
And the final one, for my dear friend's response to him is what is the risk of getting reinfected by the virus? And I've read about the Nevada case. I've read about Hong Kong. I've read about a few others.
So great question. So I just want to start with the role of antibodies. So just to clarify any misconceptions, antibodies are not a marker of current infection. Antibodies are a marker that you've had an infection in the past, and now your immune system has been able to activate, and the antibodies have been somewhat protective to the infection. So again, antibodies are not a way to diagnose current infection. Antibodies are a marker that you've had an infection in the past. Antibodies usually take around 7 days to start developing, and and their peak usually happens between 10 days to 14 days after an acute infection. How long they last, we don't know the data yet. There have been patients who've had antibodies up to 2 to 3 months after. There have been patients who have had antibodies, but those antibodies have gone down within a month or so. So we really don't have good data to suggest how long these antibodies will last. Antibodies should be protective, but again, we unfortunately, we still don't have data on whether the protection is you won't get a reinfection, or whether if you get a reinfection, it'll be a milder form of the infection. Learning from flu, it might be the latter, where having a vaccine doesn't quite completely prevent an infection, but prevents a secondary bad infection to happen. Much of the data surrounding how to use antibodies is still evolving. Unfortunately, we know that having an infection doesn't quite protect you against a reinfection. Like you were mentioning, Jeet, the Nevada case, there have been cases in Southeast Asia as well with reinfections. And in some of these cases, the reinfection has been much more severe than the primary infection. So I would like to dispel if there is a misconception that once you have been infected, you're immune for months to come. We shouldn't be lying in that false sense of security.
And with the poll that we did, with more than half saying they know someone who was positive or they were positive, I think this is a very strong message. And without naming you, my friends, please be careful. The antibody is not going to protect you. It's not a shield. It's not a once you have, I mean, you can still get corona a second time, and clearly the second time could be more stronger. That is what the empirical data is. I wanted to ask one other question, and you mentioned about plasma. And maybe if you can just explain a little bit about plasma. And I'm talking of, my question really is linked to it. If I take plasma from someone who was a COVID patient, can it be used as a preventive measure to use, to create and develop resistance? And second is, how is plasma used? When is it used to treat a COVID patient?
Okay. Again, very good question. So the whole concept about plasma is that suppose I'm infected and I've recovered. I now have antibodies. I donate those antibodies in the form of plasma. So it's called convalescent plasma, plasma obtained from a person who's recovering and has antibodies, and using that plasma in someone who is sick. On paper, it sounds great because you now are transfusing antibodies from a person who's recovering to a person who's much sick and doesn't have those antibodies yet. So on paper, it looks great. If at all, it should be used not for prevention, but for cure in a patient who is having an active infection. Using it for prevention doesn't quite make sense because those antibodies will wane away and will not protect you when the infection comes.
Right.
Now, it's been studied. There's a big Mayo Clinic trial that came out a month or so ago in terms of transfusing plasma, convalescent plasma, in patients who are acutely sick. On paper, it sounded really well, but the outcomes of that study were a negative study. So it's not part of our protocols currently. If someone was on the throes of death and we are trying to salvage and use something that has even a semblance of rationale behind it, we would use it. But that would be under throwing everything you can to salvage a patient. But other than that, we wouldn't use it. And there is unfortunately the data behind antibodies and plasma is negative so far.
Got it. So again, there is no light at the end of the tunnel as far as I see it, till we find the vaccine, and we'll come to it. There are a number of dentists and ENTs who are on the call today. And of course, Nupur is a dentist, so I'm going to ask this question. Any new learnings on their vulnerability to COVID and any preventive measures, additional protocols, which you think, you had mentioned it in very great detail the last time and explained aerosol and PPE kits and all of that. But anything new in the last 5 months?
Nothing really new, Jeej, except that the safety precautions start from the moment someone enters a busy waiting room in a physician or a dental clinic. As we know, most waiting rooms in the US and India can be quite busy with people, potentially sick people, coming in close contact with each other. So one potential way of mitigating that would be to time your appointments, making sure that people are not overcrowding your waiting room, making sure that you have masks there so that if someone doesn't come in with a mask, that person can wear a mask as soon as he or she enters, making sure there's hand sanitization going on in the waiting rooms, and making sure that there is symptom screening. So if someone doesn't have either reports a fever on entry, or someone takes a fever on entry to your waiting room, so that if that patient has a fever, you send them to home, and unless it's urgent, don't address that. Once you've come in from the waiting room to the actual clinic area, especially high-risk professions like pediatricians, where kids will always have a runny nose, and this could be COVID, this could be something very much more benign. Dental procedures where you're so close to the oropharyngeal tract and aerosolizing maneuvers all the time, those are especially high-risk interventions. And if parts of your community are seeing a huge uptick, I would suggest that you either do not do that or confine your interventions only to those that are completely urgent. And even when you're doing that, full PPE, which includes N95s, face shields, gowns, and gloves.
Great, thank you.
And this should be done on all patients, irrespective of whether they're symptomatic or not, just because there's a high incidence of asymptomatic carriers going on.
No, thank you. And a shout out to all the ENTs, the dentists on the call, and all the medical fraternity on the call. Thank you very much for what you've been doing. Vikram, I wanted to ask you to explain the CT severity score and what range is considered mild to moderate in COVID cases, very briefly.
Okay. So the CT severity score basically assesses how much of your lung is infected or inflamed by COVID. and puts a score on how much of that, like if we have 18 segments of our lungs, how many of those segments are infected with COVID. The worst case scenario being 25 out of 25, the better case scenario is 0 out of 25. I would like to just point that we shouldn't completely base all decisions just based on the CT severity score. A young, otherwise healthy patient with a bad CT severity score will probably do better than an older patient with hypertension, diabetes, underlying lung disease with a lower CT severity score. So keep it in context of the entire body. But yes, it is a way to stratify how bad the lung infection is and how bad overall the outcomes will be. I think the number goes, we don't use it as much as in the US, but I think the numbers go up to 25 as the worst number.
Okay, thank you. And very quickly, because there is still a lot of doubt and confusion around whether coronavirus is airborne transmission, whether it's a droplet infection, just to clear people's mind, air conditioning, you mentioned about the aircraft, sitting in the car with the AC on, and, a little bit about that.
Okay. So essentially, airborne transmission means that the virus particle can lie around in the atmosphere for hours after someone has aerosolized a procedure, and then if someone is exposed to those viral particles, he or she can get infected. So there's no question, COVID can be airborne. Anytime we sneeze, for example, we generate airborne particles, and if I'm infected and sneeze, that airborne transmission with COVID becomes even more pertinent. So yes, there is no question that after someone is generated an aerosol generating procedure, for example, sneezing, coughing, a wet cough, and so forth, those COVID particles can lie around in the airborne way for many, many hours to come. I would also like to emphasize that a surgical mask will not protect you against airborne transmission. The N95 would be the only place to do that, which is why if you're in a high-risk environment like an airplane or a car with the AC on, you should be wearing your N95 masks and face shields.
Okay, I'm going to move on to my next section. I still have 2 sections and less time left, so I'm going to try and run through it. Herd immunity, you briefly mentioned about it, that we are a long way away. I have a different question. Last time you left us with how to prevent it, and as the best possible scenario, you said hand washing, physical distancing, and mask wearing. Although the mask wearing may not help in development of herd immunity, and neither would the other two. My question is, does herd immunity or can herd immunity apply in human communities? Because from what I read, I understood that herd immunity came from cattle. So there's some sort of report and articles which seem to suggest that herd immunity may not be the answer.
No, I think it comes from cattle, but most other infectious diseases have been dealt with by a mass vaccination program and therefore developing herd immunity. For example, smallpox, for example, because of a very aggressive vaccination program by the WHO back in the 70s and 80s, our herd immunity is so high, we don't have to deal with smallpox anymore. Influenza, most of the rationale behind vaccinating a community up to 80-90% is so that you have herd immunity. And yes, it very much applies to a human population. That's the one way that very infectious diseases have been kept at bay for many, many decades now.
And in your view, what percentage of population needs to be affected before herd immunity kicks in?
70 to 80%.
70 to 80%. So the peak would really be the halfway mark. So it would be 35 to 40%. So if we haven't seen the peak at 35 to 40%, I don't know the empirical data, one has to go back and check, but you say 70 to 80%.
Yes.
Okay. I'm going to move to vaccine.
Sorry, Gigi, if I just may add a small thing on the herd immunity, So in the US, there was a lot of political back and forth about these lockdowns, especially in New York City. And one of the politicians that brought up that New York City had herd immunity, which is why we're not seeing an uptick. And it was very quickly shot down by the scientists saying that at best, New York City has 22% herd immunity. And that is by no means a protective level. And till a vaccine comes. So just to put in point, Sweden, one of the countries in the Scandinavian countries, adopted the model that we'll just let things flow, and we'll let herd immunity develop, and we won't shut down. And their mortality compared to neighboring Scandinavian countries is 3 to 4-fold. So just opening up everything, waiting for herd immunity to come will come at a huge expense to life.
Yeah, and I'm not an expert on the Swedish model, but I gave it a read, and I think they did it for a second reason, that the economy doesn't suffer. And when you compared it with neighbors, the economy didn't do as well either. So on both counts, it didn't work. But again, I may be there are for another day, discussion for another day. Moving on to vaccines, again, just general thought about when is the vaccine most likely to be available, as and when, and if it will be available. You as a frontline doctor, will you take it?
Yes, so that's a great question. And a lot of the news that has been come out of the vaccines, especially from the US, has been painted by a political slant. But scientifically speaking, there's a lot of vaccines in the pipeline that are being developed. Right now, there are phase 3 trials that are going on, which essentially means that there are trials going on in patients at 30, 40,000 people, patients looking not only for efficacy, but also for safety. Now that the elections are over, I feel that an unsafe vaccine will not be released in the US, and therefore the vaccine that comes out with an FDA stamp on it will be much safer now that the political pressures have gone. But that said, the vaccines, the other thing that I want to mention about vaccines is that it's been looked at least in the US, as the holy grail, that the vaccine will come and everything will be taken care of. That is a little bit of a myopic view. Having a vaccine, and the most relevant vaccine right now is the Moderna, which still requires 2 shots to boost your immunity. Having a vaccine is one thing. Deploying it to 80% of the world to get herd immunity is an entire a different challenge. And honestly, if you hear Dr. Fauci, who's the US voice of sanity in this, he's seeing this as entire 2021 before herd immunity comes. Therefore, a vaccine will be good news, but it's one step away, a huge step away from getting our entire population. There's so many differences. You have to have a cold chain to go down to the periphery. Vaccinating in deep Africa is not easy by any means, and that will take many, many months to achieve. So just that we can't forget that this is a once in a century thing that we are going through, and it's hugely inconvenient, hugely sad and tragic. But things like this come once in 100 years, and unfortunately, the few of us on the call and many others are caught in that part of history.
So you didn't answer my second part of the question. If there was a vaccine FDA approved, would you take it?
I would look at the data, but yes, now that there's no political pressure to release an unsafe vaccine, I would take it if it comes with good data behind it.
And do you think, and again, it leads me to this question, do you think the vaccine will be a solution? Or one fine day, the virus will suddenly die its own death?
There's no reason that we should expect or hope that the virus will die a sudden death. I think it's going to be in our community for eternity now, just like the influenza virus is in our community and other coronaviruses are there in our community. The vaccine is our best step to ending these numbers and these lockdowns and everything else that comes now.
Sure. I didn't understand one thing when somebody threw at me. What's the difference between rapid cure and vaccine?
So a vaccine is essential to prevent an infection. So if I take a vaccine, I hope to be protected from an infection if I get exposed to something. A cure is once you are infected, what we can do to rapidly improve that infection. So one is prevention, one is treatment.
Got it. So we may still get a vaccine, but we may still not have the cure for it, for those who have already gone through it or who haven't had a vaccine.
True.
And is there some development on the cure side as well?
Most of it, remdesivir, for example, is our best bet.
Right.
Other than that,
nothing beyond that. Efficacy you mentioned.
No, that trial shut down. Most of the other trials are shutting down.
Got it. Well, great. I know we've come to time. We started 5 minutes late, so I have a minute. I'm going to try and use that and ask you your thoughts on what we should do. Last time you left us with great thoughts at the end of the session. So till the vaccine is available, what should we be doing? And just generally summarizing from your thought, and you know, you're there in the middle of it, fighting it.
Yeah.
What should we be doing?
So, you know, even my approach to this has evolved a little bit. You know, none of this is going to go away anytime. Herd immunity, like we mentioned, is not going to go away in the next few months to come. And at some point, it becomes quite ridiculous and asked for all of us to be locked down for the entire year. So, you know, I recognize that many of us will have at some point have to break a threshold where we venture out in the community. And that will be a different threshold for many of us. Many of us can work from home. Many of us will be compelled to work in an office. I would just like to reemphasize that knowing that this is not going to end anytime soon, if you have to go out to work, I would hope that you don't socialize as much, but you have to go out to work just to, you know, sustain your family. You do that in a very protected way, masking you and people around you, wearing a face shield, wearing an N95 if you're in a high-risk environment, would be still to do. I depart a little bit from my earlier dictum that you cannot go out at all, because that becomes a little bit difficult to implement for another year. So if you do go out, do go out in as safe a way as you possibly can.
Well, that's been immensely helpful. I don't think there's more that we could have learned in that 1 hour that we had. Eternally grateful on behalf of everyone for you to have taken the 1 hour out of your family time. I know it's tough times, and I know you would do it because of our relationship. But you know, it's amazing what you are doing. It's amazing what the likes of you are doing. So more strength to you and each one of the frontline workers. Thank you so much. Our compliments, our best wishes, our prayers for your safety. That's all I would tell you. For those of you who are attending and listening, and even on Facebook, please continue to take good care of yourself. The message is very loud, very clear. You need to continue to adopt well. It is still uncertain times. 5 months after we spoke with Dr. Vikramjit Mukherjee, it has not ended. So please do not drop your guard. I know there are lots of questions which remain unanswered, but there's only that much we could pick up today. So apologies if we couldn't answer your specific question. This session has been recorded. It will be saved. It will be shared on the group, on the WhatsApp group. It will remain on YouTube. It will remain on Facebook, along with all the other lockdown conversations. So please feel free to go back, feel free to share, create as much awareness as possible. Even if we have helped one person, it would be amazing. And that's why we are doing all of this. If anybody has anything to say, please feel free, unmute yourself, speak up, and please have a happy Diwali, have a safe Diwali, stay well, stay safe till we meet again.
Very much, John, and thanks, Sujeet, for your time and these words of wisdom. Thank you very, very much.
Thank you very much, Ravindra, and thank you so much, Vikram. Both my son-in-laws, you've done a wonderful job of keeping us abreast with the latest update on this deadly condition, really, which we are all trying to protect our family and all to God. Thank you.
Love you both, beta.
And Dr. Santosh, convey my good wishes to both of them.
Thank you, Chiranjeev. Thank you.
Thank you, sir. Thank you.
Thank you, everyone. We will bring this session to an end. And thanks again, Vikram. It's been a pleasure. Samuel, you can save this.
Thank you so much.
Thank you.
Thank you.
Vielen Dank. Bye-bye.
Thank you.
Tschüss.
Thanks
Thank
everyone.
you.
Thanks.
Thank
Thank
you.
you.
Thank
Bye-bye.
you. Thank you,
Bye.
everybody.
Thank you.
Thank
Thank you. Thank you.
Thank you, RJ. Bye.
Thank you very much, Ravindra. Wonderful time and
Thank you.
very
Thank you.
educative.
Thank you very much.